Good morning, everyone. This is Daniel Lin. I'm from Thomas Jefferson University Hospital and medical oncologist. And we're here at the GI cancer discussion panel. And I'll have my colleague here introduce himself as well too.
Hi, everyone. For those who don't know each other, Arturo Loaiza Bonilla from Cancer Treatment Centers of America. Looking forward to having an ongoing discussion in this meeting today. We are going to start with a GI malignancies review, and we have a few questions, I believe, from the audience that we would love to go through. I think we answered some of them on the chat, but it's always good to have kind of like the ongoing discussion on this. So I think you can start with a few of the questions that came in my session. So the first one is, how do they explain the overall survival in both groups were almost the same? Well, I wouldn't say it was almost the same. I think they started to approximate each other compared to the PFS data that we saw. But as we noted, there was an effective 60% crossover rate. And even with those results, we were still able to see an overall survival advantage for pembrolizumab, regardless of the group that was included. So I think with that, we still feel confident of the results and thinking of pembrolizumab as still the standard of care for first line in MSI high colorectal cancer patients. The other question we had is, what is the recommendation for ipilimumab and nivolumab in first line MSI high, given there's no head-to-head comparison with monotherapy pembro? Absolutely. So at this point in time, we don't have any data on the first line setting in terms of ipi-nivo, but we're looking forward to have more data in the future. We know for sure that we can still use ipilimumab, nivolumab in second line for a bunch of our patients. I've seen cases of patients getting rescued, quote unquote, from single agent PD-1 inhibitor, using that. And for patients who otherwise may not have the exposure, then you can certainly use it. But in first line, still, the jury is still out. We're probably going to find information, given the data from all the disease types, is not. It wouldn't be surprising if we see that actually it's going to be improved PFS and maybe a little bit of advantage of OS in the future, but more to follow on that specific. Other question was, is there any new data in KRAS mutated colorectal cancer? I believe it's in the context of the Keynote 177. There is some data in the subgroup analysis showing that KRAS mutations had a less benefit. I mean, there still was benefit favoring pembrolizumab, but less prominent than in KRAS wild type. The reason for this is still unclear. It could be the impact of subsequent lines. It's hard to really conflate it, but still the benefit holds. But the question is, should we favor chemotherapy at this point in time? I don't think that we have that as an option right now. I think pembrolizumab is still the first option for these patients, unless there's a major contraindication. And lastly, is the use of pembro in MSI high tumors recommended even for KRAS and BRAF mutations? That's a follow-up question basically on what I just mentioned. Yes, even with the subgroup analysis showing us that some molecular settings have less responses, we still see the benefit of immune therapy, the priming phenomenon, or overall survival benefit that we can see regardless of therapy. Of course, it doesn't preclude us from using BRAF inhibitor combination in the second line and beyond. And it just gives us the most options, if anything. And those are my questions. I think there's a question for Dr. Lin right now. Good.
All right, so I see a question here regarding residual disease after FLOT, and would you use immune therapy or complete FLOT? So I'm presuming this is for probably more gastroesophageal cancer. So recall that Checkmate 577 for adjuvant nivolumab was for patients who had neoadjuvant chemoradiation, esophageal G-junction cancer, surgery, and then adjuvant nivolumab. If we're talking about a perioperative setting with chemotherapy alone and using FLOT alone, there's really not have the data yet to suggest use of immune therapy pre or post. So I think that is yet to come. There are ongoing trials that are trying to answer that question. So at this time, I would probably still continue the FLOT chemotherapy. In terms of, there's a question here for, is the use of nivolumab plus chemotherapy for all patients regardless of PD-L1 status? So if this is in reference to specifically squamous cell cancer, the current FDA approval for squamous cell in the advanced setting is actually with pembrolizumab and chemotherapy. For nivolumab and chemotherapy, I think we're still pending the regulatory approval for squamous, though I think that for PD-L1 status, as we saw here in that study, they in 648, checkmate 648, they primarily used TPS. From what Ian Chow had presented at ASCO, there's a report that a large majority of patients had at least a CPS positive score, but we still need to see that data. So as it stands right now, I think that what we see from that study itself from 648, that there is a benefit for all patients in squames, and there's a particular benefit, I think, for those who are PD-L1 positive. But again, just keep in mind that that study used TPS scoring. And another question for optimal first line for metastatic HER2 negative, PD-L1 negative adenocarcinoma of the G junction. So this is a little bit out of the scope of the abstracts, but I think it's a very good question. So we're talking about adenocarcinomas and PD-L1 negative, so presumably CPS negative. And I think that has been a strong area of debate. We saw in checkmate 649 that there was a particular benefit for a CPS of 5 or more. Interestingly, the FDA approval came for all comers, so regardless of PD-L1 score. I think there have been some arguments that CPS, there's some sort of subjectivity about it, and that you know, what's the difference really between a CPS of 4 or 5? So I think that there is benefit for immunotherapy, nivolumab with frontline chemotherapy, definitely for the CPS 5 or more, potentially for the PD-L1 CPS 1 or more. I think the data, at least that we've been presented with from 649, doesn't as clearly support PD-L1 negative, even though there is FDA approval for it. There was an analysis that was reported on that actually showed there wasn't a significant improvement in survival for that subset of patients who were PD-L1 negative. So I probably wouldn't be as in support of adding immunotherapy to chemotherapy if you're PD-L1 negative, but there is FDA approval for it. Another question I see here, what would sway you more towards IO versus chemo IO? So I'm assuming this is in regards to the esophageal study again for the squamous cell population, the checkmate 648 study. So, you know, that's a really good question. I think the data itself for IO was, you know, provocative. It was certainly compelling to use a chemo-free, completely chemo-free option, and certainly there were a group of patients that derived significant benefit, and we saw that in the IO population. Those who did respond actually had the longest duration of response, even longer than nivo plus chemo, but that's probably not too surprising if they are going to respond to IO. That being said, I think based upon that study, I would be hard pressed to know what exactly, what type of patient would benefit the most from IO. I think chemo plus IO is the first standard. And potentially in some patients who you may, whether it's comorbidities or something that makes you think that they may not tolerate chemotherapy well, maybe you can try IO in that setting. Another question here. What neuropathic medications do you use with little concern of interaction with traditional medications? Arturo, do you want to take a stab at this?
Sure. Yeah, yeah, out of the scope, but yeah, it's like kind of label question, but not really. I mean, having the what I use mostly for neuropathy is, you know, what the data that we have already is mostly for you know, Cymbalta. That's what I use more often in my patients. I check for my with my pharmacist and see what can we use differently. There's any interactions with them, and I consult with my palliative care team to see if we can use something else. Sometimes we use Neurontin, but I don't know what else to say on that specific yet.
Yeah, I probably have the same response. I think duloxetine Cymbalta is the SSRI probably with the least amount of interactions with most chemotherapy, and that's what has been studied. I also have sometimes used Neurontin, sometimes Lyrica, but yeah. So I have a question for you, Arturo. In terms of colorectal cancer, what is your general strategy? We've looked at some maintenance studies, and do you favor use of, for example, if you're going to do maintenance, fluoropyrimidine alone, fluoropyrimidine combined with a biologic, when do you consider maybe a stop and go approach?
Yeah, no, that's a very interesting question. I mean, we had some results, the Focus 4N trial showing that capecitabine is an appropriate discussion to have in terms of maintenance. I tend to do maintenance. I think my patients and myself, we feel a little bit nervous to stop completely unless the patient has a significant side effect that really prompted to stop everything altogether, like a prolonged hospitalization or something like that. I tend to use to keep the capecitabine or the 5-FU for those patients and have a discussion about the biologic, because that sometimes may be the limiting step. If someone is on capecitabine, then the patient can be monitored remotely, doesn't have to come as often. But if someone is on 5-FU, then there's a little bit more frequency in the visit. So I tend to change to capecitabine if I can. I have a discussion about the biologic. Certainly, if ever we're going to use a biologic, I always combine it with a fluoropyrimidine of some sort, because there's data already showing that that's where you get the most benefit out of the whole approach, and also a cost-effective approach as well. So I tend to do pretty often capecitabine and you know, the bevacizumab or biosimilar with that. And the same if I'm using a biologic such as an EGFR inhibitor, I tend to combine it. Based on the data, we know that single agent EGFR inhibitors don't really do any benefit. They only do work when we use them as maintenance with fluoropyrimidine. So that we might take in. There's some data with the S1, et cetera, but we don't have those agents here in the United States. Hopefully we will have them at some point, but that's my overall discussion on this. Yeah. And for your end, so I'm glad the fact that you mentioned that the CPS score between 4 and 5 is challenging. So will you see the field evolving based on the upcoming data for combinations? Are we going to stick with the CPS score of 5, as some people are saying? What are the other things that we should be looking for those patients?
So are you talking about in terms of the cutoffs?
Yeah, the cutoffs. Yes.
You know, I think that's a really good question. The NCCN recently put out their guidelines, and they did stipulate that there is seems to be greater benefit from the higher CPS scores versus the lower, but it can still be considered. So I think in terms of IO plus chemotherapy up front, I think it'd be far more compelling for at least some positivity, whatever that may be, for PD-L1 score in terms of benefit as opposed to PD-L1 negative.
Okay, that's, I mean, absolutely interesting, and see what happens with all the things coming. So thank you so much, Dr. Lin, and everyone in the audience. Now it's time to take a break, the perfect time to earn some points in the Engage and Win giveaway by chatting with the industry reps in the exhibitor hall. With their booths, you will find very helpful resources and information as well. They're ready to talk to them with your booth representative. So thank you again, and wishing you a rest of wonderful meeting today.